Imagine this scenario. You're on service in the ICU, and a patient, perhaps someone you initially admitted for, maybe a routine post-op complication or what seemed like a straightforward infection, suddenly takes a really sharp turn for the worse.
Yeah.
They rapidly develop unexplained multi-organ failure, their kidneys shut down, their lungs become unresponsive to ventilation, their brain shows signs of acute encephalopathy, and you're seeing widespread, disseminated thrombosis all within maybe just a matter of
That's a
days.
terrifying picture.
It is. It's a life-threatening clinical puzzle, a true medical emergency demanding immediate recognition and, well, really aggressive, often multidisciplinary management.
And this is precisely the kind of rapid critical deterioration that pushes even the most experienced intensivists to their absolute limits.
Yeah.
It represents a complex hypercoagulable state where, every single minute counts, and that diagnostic window is incredibly narrow.
Absolutely. And today, we're embarking on a deep dive into the condition that can cause such a devastating acute presentation. Antiphospholipid syndrome, or APS, and more specifically, its most aggressive and frankly terrifying variant, catastrophic antiphospholipid syndrome known as CAPS.
Right. And while antiphospholipid syndrome itself is considered, well, uncommon, maybe 5 per 100,000 individuals in the general population, the catastrophic form, CAPS, is truly rare, but absolutely critical for intensivists.
Critical.
It's a dire emergency with a mortality rate that, despite significant advances in critical care and targeted therapy, still hovers around a grim 20 to 30%.
Wow.
And this persistent high mortality really underscores the urgent need for every critical care intensivist to be profoundly proficient in its rapid identification, the nuanced diagnostic workup, and of course the aggressive multimodal management.
Our mission in this deep dive is, well, it's ambitious. We aim to provide you, the critical care intensivist, with an unabridged board exam caliber understanding of both APS and its catastrophic variant, CAPS. We're going to dissect its incredibly complex pathophysiology, right down to the molecular level. We'll explore its diverse and often surprising clinical manifestations that go way beyond simple blood clots. We'll unpack the subtle diagnostic nuances that are just vital for early recognition in that fast-moving ICU environment, and then critically evaluate both current and emerging therapeutic strategies, especially those most relevant to your practice in the ICU.
Ultimately, our goal is really to equip you with the deep knowledge needed to not only identify these challenging patients quickly, often when their symptoms are, let's face it, ambiguous,
Right.
but to manage them effectively, making informed, potentially life-saving decisions, and ultimately improving their outcomes in the face of what is often a devastating prognosis.
So let's lay out our roadmap for this journey, just give you a high-level overview of where we'll be focusing our attention. We'll begin by clearly defining antiphospholipid syndrome and really delving into its fundamental two-hit pathogenesis that's crucial for understanding its clinical expression. Then we'll move into the microscopic world, meticulously unpacking the molecular drivers of thrombosis and inflammation, identifying the bad actors at play. After that, we'll broaden our view to look beyond just the obvious blood clots, examining the wide spectrum of APS manifestations across various organ systems, including those extra criteria presentations that can be diagnostic clues.
Right, the less obvious ones.
Exactly. Then we'll arrive at the heart of our discussion. Catastrophic APS, or CAPS, which we're calling the thrombotic storm unveiled. We'll get into its defining characteristics and triggers.
The storm itself.
The storm itself. From there, we'll transition into the crucial aspects of navigating ICU management, focusing on the essential triple therapy and its critical adjuncts. We'll then explore the exciting frontier of emerging therapies and future directions, looking at what's on the horizon. Finally, we'll wrap up with vital practical considerations for you in critical care, including differential diagnoses and interactions with other systemic illnesses. So let's jump right into Chapter 1, defining antiphospholipid syndrome and its core pathogenesis.
Okay, so to begin, let's establish a foundational understanding. Antiphospholipid syndrome, or APS, is medically defined as an acquired immune-mediated thrombophilia.
Right.
Breaking that down, it's an autoimmune disorder, meaning the body's own immune system mistakenly produces antibodies that attack certain proteins bound to phospholipids on cell surfaces.
Okay.
This immune attack leads to a propensity for blood clots forming within blood vessels, arteries, veins, or face. It can result in specific complications during pregnancy, like recurrent miscarriages or severe preeclampsia.
Ah.
The defining characteristic of APS is that these clinical events happen specifically and persistently in the presence of detectable antiphospholipid antibodies, or APL.
Hmm.
It's really the combination of the clinical events and these specific antibodies that defines the syndrome.
So it's an autoimmune condition, predisposes you to clotting, severe pregnancy issues, and it's all linked to these specific pathological antibodies.
Hmm.
What exactly are these key antibodies we should be testing for, and how are they usually detected?
Right, the primary autoantibodies we focus on for diagnosing APS are lupus anticoagulant, often called LA, anticardiolipin antibodies, or ACL, and anti-beta-2 glycoprotein I antibodies, known as A2GPI.
The big three.
Those are the big three, exactly. They're typically detected through specific lab tests. Lupus anticoagulant, that's identified via functional coagulation assays that measure its effect on clotting times,
Okay.
whereas anticardiolipin and anti-beta-2 glycoprotein antibodies are usually detected using solid-phase immunoassays, most commonly ELISA enzyme-linked immunosorbent assay.
Got it.
It's worth noting, while you might sometimes find IgA isotypes of ACL and anti-GPI, an isolated IgA anti-GPI has been sporadically linked to thrombosis, current international recommendations generally don't support routine testing for them. Their clinical significance is just less established compared to the IgG and IgM isotypes.
Okay, that's clear. And how common is this syndrome, broadly speaking, epidemiologically?
Well, APS is considered uncommon in the general population, estimated at roughly 5 per 100,000 individuals, maybe one new case per 100,000 per year.
Okay.
However, that overall rarity kind of belies its disproportionate representation among certain clinically important groups. For instance, it's a really significant consideration in young patients presenting with otherwise unexplained thrombosis, DVT, PE, acute ischemic strokes.
Especially in young people.
Especially in young people, yes. Similarly, it's a critical diagnosis to consider in women experiencing recurrent pregnancy losses, particularly those later in pregnancy, or severe obstetric complications like HALP syndrome or preeclampsia. So while it's rare overall, it's a diagnosis that should definitely jump to the top of your differential in those specific high-stakes clinical scenarios.
That's a clear profile for when to suspect it. Is APS always a standalone condition, or does it sometimes show up, with other autoimmune diseases or other underlying conditions?
That's an excellent and crucial distinction. It leads us to differentiate between primary and secondary APS. Primary APS is diagnosed when the syndrome manifests independently. There isn't an underlying, well-defined autoimmune disease driving it. These patients just develop APL and the associated clinical events on their own.
Okay.
Secondary APS, on the other hand, occurs in conjunction with another underlying autoimmune disorder. The most notable and frequent association here is with systemic lupus erythematosus, SLE.
Right, lupus.
Exactly. A significant chunk, maybe 20 to 40% of SLE patients, will test positive for antiphospholipid antibodies. In fact, APS is considered a major contributor to morbidity and mortality in SLE.
Wow.
Occasionally, secondary APS can also pop up with other autoimmune conditions like Sjogren's syndrome or rheumatoid arthritis, or sometimes in the context of infections. Certain medications, though, those antibody responses are often transient, or even underlying malignancies, which can create a procoagulant state. It's vital for intensivists to remember that transient APLs can appear during acute infections, like severe sepsis or viral illnesses, or even in some apparently healthy older folks. But these usually don't progress to full-blown persistent APS or require long-term anticoagulation unless, of course, a thrombotic event happens.
That distinction between transient positivity and persistent, clinically significant APS sounds absolutely vital for, accurate diagnosis and management. How do clinicians officially classify APS, especially with these newer criteria coming out?
Yeah, for many years, the standard framework has been the Sidney criteria, which are actually the revised Sapporo criteria. These require at least one clinical criterion, either documented vascular thrombosis, arterial, venous, or small vessel, or a specific pregnancy morbidity, like recurrent early miscarriage, late fetal death, or severe preeclampsia.
Okay.
And at least one laboratory criterion, meaning persistent positivity for lupus anticoagulant, anticardiolipin antibodies, usually IgM above 40 GPL-MPL units, or anti-beta-2 glycoprotein I antibodies, IgM above 40 SGU.
And the persistence is key, right?
The persistence is absolutely key and still incredibly relevant. It typically means confirmed detection on 2 separate occasions at least 12 weeks apart. This is specifically designed to differentiate true pathologically relevant APS from those transient antibody phenomena we just talked about.
Right.
Now, it's important for intensivists to know that new classification criteria for APS were proposed in 2023 by a joint task force from the ACR and ELAIR American College of Rheumatology and European League Against Rheumatism.
Okay, the new ones.
Yes, these new criteria represent a significant refinement. They divide the clinical criteria into 6 distinct domains: macrovascular thrombosis, microvascular thrombosis, cardiac valve disease, neurological involvement, hematological issues, and obstetric complications.
More detail.
Much more detailed. And the lab criteria are simplified into 2 main domains: functional assays for LA and immunoassays for ACL and A2GPI. A big advantage of these 2023 criteria, beyond the comprehensive clinical assessment, is their exceptionally high specificity, 99% compared to 86% for Sapporo.
Wow, that's much better.
It helps minimize overdiagnosis. They also incorporate risk stratification and hierarchical clustering, giving a more nuanced approach. For instance, a higher score is given for high-risk antibody profiles like triple positivity. This really reinforces the need for meticulous evaluation and, critically, that persistent antibody positivity.
Okay, so the antibodies are present, they're persistent, but we know they don't always cause problems just sitting there. This brings us to the famous two-hit hypothesis, which seems fundamental to understanding how APS actually manifests clinically. How exactly does that work? What's the core concept?
Precisely. The two-hit hypothesis is a cornerstone for understanding APS pathogenesis, especially why patients with circulating APL don't constantly thrombose, but can suddenly develop severe widespread clotting. The core idea is that antiphospholipid antibodies, the APLs, provide the first hit.
Hit number one.
Hit number one. They create a generalized underlying procoagulant state. Think of it as priming the system, making the blood inherently a bit more prone to clotting, a subtle predisposition. But this procoagulant state often remains subclinical, asymptomatic, maybe causes only minor issues, until a subsequent second hit occurs.
Hit number two.
Hit number two. And this is often a sort of cryptic or hidden stimulus like a vascular injury, a systemic inflammatory event, maybe even a sudden change in their coagulation status. It's this secondary event that then tips that precarious balance firmly toward coagulation, unmasking an exaggerated and often catastrophic thromboinflammatory state.
So it's not just having the antibodies, something else, some additional insult has to happen to actually trigger the clinically significant clotting. Is there good experimental proof for this two-hit idea beyond just seeing it happen in patients?
Yes, there's compelling experimental evidence supporting it strongly. Many APS manifestations, including thrombosis and fetal loss, can be successfully reproduced in animal models by transferring patient serum or immunoglobulins containing these pathogenic antibodies into the animals.
Okay.
However, and this is the critical part, validating the model simply infusing the pathogenic APLs into animals doesn't on its own cause spontaneous thrombosis.
Okay.
To induce a significant thrombotic event, you invariably need to introduce some form of disruption or stimulus. This could be a physical injury to the vessel wall, like a needle prick or a clamping, mimicking trauma or surgery.
Right.
Or an alteration of blood flow, causing stasis. Or even infusing immune stimulants, like LPS from bacteria, or histones released during cell death. This experimental evidence clearly shows that while APLs prime the system, create the vulnerability, a secondary stimulus is almost always required to kick off the full-blown coagulation.
That's fascinating, really bridging the lab to the bedside. So what are some of the most common and critical second hits that we as intensivists might encounter in clinical practice? The things that actually kick off these devastating events in our patients?
In real-world settings, especially the ICU, these second hits are often readily identifiable, and recognizing them is critical. Common examples include systemic infections, severe sepsis, pneumonia unleashing that potent inflammatory response.
Right, infection's a big one.
A huge one. Major surgical procedures, particularly those with extensive tissue damage or vascular manipulation, acts as a second hit due to the combined stress, injury, and inflammation.
Makes sense.
Significant physical trauma, especially multisystem trauma, can also trigger it. An underlying malignancy due to its procoagulant and inflammatory effects is another known trigger. Physiological states like pregnancy, particularly the third trimester and postpartum period, are high risk due to inherent hypercoagulability and inflammation. And crucially, something to be acutely aware of in the ICU, The abrupt discontinuation of anticoagulation or maintaining a subtherapeutic INR, especially in patients already on warfarin for APS, is a significant avoidable trigger. It contributes to about 8% of CPS episodes.
This two-hit concept is so fundamental you can almost picture it, right? Like a precarious balance on a seesaw. The antiphospholipid antibodies load one side, creating this subtle, chronic tilt towards clotting, setting up the danger. But it takes that sudden push in infection, surgical stress, trauma, even stopping their blood thinner to send that seesaw crashing down into a full-blown runaway thrombotic event. It's often not a gentle nudge, it's a precipitous collapse.
That's a perfect analogy. It really illustrates how a quiescent procoagulant state, just lurking in the background, can rapidly and dramatically escalate into a life-threatening thrombotic episode when the right, often severe, trigger appears. This sudden shift from latent risk to acute crisis is exactly what intensivists need to be ready for.
Okay, let's just unpack this for a second, consolidate our understanding. So far, we've established APS is an acquired immune-mediated thrombophilia, driven by specific antibodies, LA, ACL, a 2-GPI needing persistence for diagnosis. And critically, its full clinical expression, especially the severe forms like CIPS, hinges on this two-hit mechanism. An underlying procoagulant state from the antibodies is suddenly unleashed by a precipitating inflammatory or injury event. Understanding this fundamental concept, that delicate balance tipped into crisis, is absolutely crucial, especially when you're facing that rapid onset of multi-organ dysfunction that characterizes catastrophic APS in the ICU. Now, for a board-style question to test that understanding in clinical application, a 35-year-old female with known primary APS is admitted to the ICU with severe sepsis from necrotizing pneumonia. Over the next 24 hours, she rapidly develops AKI needing CRRT, respiratory failure needing high-frequency oscillatory ventilation, and altered mental status with new focal neurological deficits. Which of the following best describes the underlying principle contributing to her rapid worsening condition? A, overproduction of immune complexes in the lung causing direct cytotoxicity. B, direct cytotoxic effect of APLs on parenchymal cells causing necrosis. C, a second hit inflammatory stimulus, her sepsis, unmasking and escalating her pre-existing procoagulant state. Or D, impaired fibrinolysis leading to widespread hemorrhage.
Okay, the correct answer here is definitely C. Her severe sepsis from pneumonia is that potent inflammatory second hit. It dramatically escalates her underlying procoagulant state from APS into severe, widespread multi-organ thrombosis and dysfunction. The other options, they describe mechanisms not primarily at play, or in the case of D, kind of the opposite of what's usually seen in APS thrombosis.
Perfect. Let's move on to Chapter 2, unpacking the molecular drivers of thrombosis and inflammation. This is where we really get into the nitty-gritty of how these antibodies wreak so much havoc.
Right. Understanding the precise molecular mechanisms is, admittedly, quite complex, mainly because of the considerable heterogeneity in antiphospholipid antibody profiles. Standard lab testing probably only shows us the tip of the iceberg in terms of the full diversity and function of these antibodies. But despite that challenge, numerous bad actors have been robustly implicated. These include various blood cells, platelets, red cells, white cells like neutrophils and monocytes, key complement proteins from the innate immune system, and critical components of both the coagulation and fibrinolytic systems. They all seem to play a concerted role in orchestrating this exaggerated thromboinflammatory state.
So it's not just one thing, it's a whole cast of characters working together. Let's start with the vessel walls themselves. Normally, they're smooth, antithrombotic. How do these antibodies actually attack the endothelial cells lining our blood vessels?
Endothelial cell activation is a critical early step. It transforms that normally quiescent antithrombotic lining into a prothrombotic surface. In the lab, APLs have been robustly shown to directly activate healthy cultured endothelial cells.
Okay.
This activation leads to a dramatic shift in their phenotype. They start expressing adhesion molecules on their surface and significantly ramp up production and exposure of tissue factor.
Tissue factor, the trigger.
Exactly. What's mechanistically fascinating is that APLs effectively co-opt or hijack pathways normally associated with non-autoimmune inflammatory stimuli. They manipulate the body's own defense and repair mechanisms to promote clotting instead of preventing it.
That's a profound subversion of normal physiology. How does that hijacking happen at a deeper level? What specific receptors and intracellular signaling pathways are involved?
Well, it typically starts with APLs engaging specific receptors on the endothelial cell surface. The most well-studied is apolipoprotein E receptor 2, ApoER2, Others might be involved too.
Okay.
This initial engagement triggers a complex intracellular signaling cascade. We see activation of key inflammatory pathways like NFB and P38, MAPK. And it's important to recognize these are the same fundamental inflammatory pathways central to many other states we manage in the ICU, like sepsis or ARDS.
Right, the usual suspects.
The usual suspects, leveraged by APLs. Simultaneously, there's a crucial suppression of certain vasculoprotective factors called Kruppel-like factors, or KLFs, which normally help maintain endothelial health. And modulating these pathways, activating NFB and P38 MAPK, suppressing KLFs, has major downstream effects. It suppresses anti-inflammatory transcription factors, reduces nitric oxide anosynthesis, creating a dysfunctional endodepleted state, and critically, significantly increases tissue factor synthesis and expression.
Is there strong evidence this happens in living systems, not just a petri dish? What does the in vivo data show?
Yes, the evidence is compelling. In mouse models of APS, giving APLs significantly increases tissue factor activity in carotid artery homogenates. That's strong in vivo evidence.
Okay.
Furthermore, APL administration to mice markedly increases leukocyte endothelium interactions, white blood cells sticking aggressively to vessel walls. And researchers have protected mice from APL-mediated thrombosis by disrupting key adhesion molecules like E-selectin, P-selectin, PSGL1, VSAM1, or ICAM1.
So blocking the stickiness helps.
Exactly. It powerfully highlights the crucial role of these adhesion molecules in enabling inflammatory cells to adhere to the activated vessel wall and kick off clotting.
That's a remarkably detailed look at the vessel wall compromise. But what about the immune cells? How do neutrophils, platelets, other circulating cells contribute to this pervasive prothrombotic state?
Immune cell involvement is incredibly significant, multifaceted. For instance, way back in the 90s, before we even fully grasped NETs, it was found that mouse monoclonals against human beta-2 GPI could directly activate neutrophils, causing degranulation and hydrogen peroxide production.
Wow, early evidence.
Early evidence. Then, in the early 2000s, pivotal experiments in pregnancy models of APS further ID'd neutrophils and complement as vital mediators of fetal injury, showing their direct pathogenic role.
And in the lab with human cells, does that activation translate?
Absolutely. In vitro experiments with human cells clearly show various human monoclonal APLs induce robust neutrophil activation measured by oxidative burst, increased phagocytosis, shedding of L-selectin. These prothrombolus phenotypes were further potentiated when combined with toll-like receptor PLR signals like LPS, mimicking bacterial infection, or PAM3-size4. This demonstrates powerful synergy between APL and common inflammatory signals, explaining why infections are such potent second hits.
Right.
Another key study found control neutrophils cultured with APS serum showed markedly increased tissue factor expression. And critically, in that system, complement activation, specifically the C5a receptor, was required for maximum expression, highlighting the interconnectedness.
That brings us to neutrophil extracellular traps, or NETs. They've gotten a lot of attention lately in various thrombotic conditions. How do these sticky structures fit into the APS picture?
Indeed, NETs are now seen as major drivers of thromboinflammation in APS. When neutrophils get activated, especially by inflammation or APLs, they can undergo necrosis, releasing a mesh of DNA, histones, and granular proteins like elastase.
The spider web analogy.
It's exactly. This net formation is seen in animal models of DDT. Seems crucial for clot formation. Interestingly, platelets can also induce nets, further cementing the link between immune cells and coagulation. Clinically, these nets actively contribute to thrombosis. They provide a physical scaffold for clot propagation, trapping red cells and platelets, and directly activating coagulation factors, a perfect prothrombotic substrate.
So if you're picturing this, think of NETs as that biological spiderweb neutrophil spin, not silk, but a sticky prothrombotic mesh of DNA, histones, granular proteins forcibly released. This web acts like a literal sticky trap, capturing red cells and platelets, providing a perfect scaffold for rapid clot propagation and vessel occlusion. It transforms inflammation directly into thrombosis.
That's a highly accurate and vivid image, and beyond neutrophils, those leukocyte endothelium interactions are significantly increased by APLs in mice. Again, disrupting adhesion molecules like E-selectin, P-selectin, PSGL1, V01, or ICAM1 protects mice from APL-mediated thrombosis.
Underlines their role.
Absolutely. Platelet activation, maybe overshadowed before, is increasingly recognized as key. APLs directly activate platelets to aggregate, and monocytes are implicated too, showing increased tissue factor expression, particularly in primary APS, further fueling coagulation.
All these players working together, endothelium, neutrophils, platelets, monocytes, their mediators, sounds like a finely tuned but ultimately destructive orchestra. What about the complement system? You mentioned it earlier as a bad actor. Seems central in many severe autoimmune conditions.
Complement indeed plays a central and critically often uncontrolled role in APS pathogenesis, especially in CAPS. Strong evidence backs this. For instance, a high prevalence of complement regulatory gene variants mutations in CFH, CFI, CD46, C3 are found in up to 60% of CAPS patients.
60%. Wow.
Yeah, these genetic predispositions likely contribute to their inability to restrain complement amplification once triggered. This suggests those precipitating events, surgery, infection, pregnancy, might serve as potent complement-stimulating second hits in someone whose regulatory genes can't put the brakes on, leading to a runaway reaction.
So, picturing the complement cascade in CAPS, it's like that self-amplifying fire alarm system gone haywire. Normally, it targets threats precisely. But in CPS, it's like the fire sprinklers are stuck on full blast, dousing healthy tissue too, causing widespread damage. It just runs wild, unchecked.
Exactly. This uncontrolled activation generates potent inflammatory mediators, C3A and C5A, powerful anaphylatoxins,
Yeah.
and leads to the C5b9 membrane attack complex formation. These products directly fuel endothelial activation, platelet activation, tissue damage, driving that rapid, widespread microvascular occlusion of CPS. It becomes a vicious cycle. Inflammation drives thrombosis. Thrombosis drives more inflammation.
Here's where it gets really interesting for us as intensivists, connecting molecular dots to the clinic. We've dived deep into the microscopic battleground. It's clearly not just antibody presence, it's a complex interplay. APLs provoke endothelial cells, turning smooth vessel linings sticky and procoagulant.
Right.
They activate neutrophils, unleashing destructive nets as clot scaffolds. And crucially, especially in catastrophic cases, they unleash uncontrolled complement, setting off a runaway inflammatory and clotting reaction devastating the microvasculature. This multi-pronged attack relentlessly drives the hypercoagulable state. Now, for some spaced repetition and mnemonics to solidify these complex concepts, first, remember the core two-hit hypothesis. APLs are hit 1, creating the baseline procoagulant state. Injury or inflammation is hit 2, triggering full-blown thrombosis, both needed for the dramatic picture.
Got it. And for the key cellular players. Remember, endothelial cells get activated, become prothrombotic. Neutrophils release sticky procoagulant nets. Platelets activate, promote clotting and more netosis. And monocytes add to tissue factor expression, initiating coagulation.
Perfect. Finally, key molecular players. Think tissue factor, the primary initiator. Adhesion molecules like selectins, integrins, mediating cell vessel stickiness. NFKB and P38MAPK, the hijacked inflammatory signaling pathways. And of course, complement, unleashing that devastating, self-amplifying storm fueling SEC-PS. Let's move to Chapter 3. Beyond thrombosis, the wide spectrum of APS manifestation. This is where we learn to spot APS even when it's not presenting in the typical ways.
Right. When we think APS, thrombosis comes first, and rightly so, it's the hallmark. APS affects vascular beds of all sizes,
Yeah.
arterial, venous, microvascular, throughout virtually every organ.
Everywhere.
Pretty much. Most frequent venous sites are lower extremity deep veins, DVT, potentially leading to PE. For arterial thrombosis, cerebral arteries are most common ischemic strokes, TIAs, especially in younger patients.
But it's not just the usual DVT or stroke, is it? APS can show up in really unusual places, making diagnosis harder.
Precisely. Thrombi can form in sites uncommon in the general population, often overlooked but devastating. Arteries supplying viscera, leading to ischemic gut, mesenteric ischemia, bowel infarction,
Oh, wow.
venous sinuses around the brain, causing cerebral venous sinus thrombosis, leading to intracranial hypertension, seizures, severe deficits. Beyond large vessels, there's significant risk for widespread microvascular thrombosis. Skin, unique patterns, eyes, visual loss, heart, lungs, kidneys, any organ leading to diverse, often confusing presentations, especially in the critically ill.
Speaking of the heart, what specific cardiac manifestations do we see with APS beyond standard coronary disease?
Cardiac involvement can be quite varied, distinct from typical atherosclerosis. Valvular heart disease is common, often as non-infectious sterile vegetations, Liebman sacs, endocarditis.
Right.
These can cause regurgitation or, less often, stenosis, especially mitral and aortic valves. MI, while less common than VTE, can happen, especially in young patients without traditional risk factors, from coronary artery thrombosis. Another big concern, especially in critical care, is intracardiac thrombosis. Clots forming directly in heart chambers, particularly atria, even without AFib or severe heart failure. These greatly increase systemic embolization risk strokes, peripheral occlusions, splenorenal infarcts.
So a clear impact on major vessels and the heart. What about those extra criteria manifestations beyond classic thrombosis and pregnancy loss that might provide crucial clues, especially in a critically ill patient whose diagnosis isn't obvious?
These are key for intensivists, often the initial perplexing clues in unexplained multi-organ dysfunction. Dermatologically, levato reticularis and racemosa, that net-like reddish-blue skin discoloration, often tree branch patterned, signaling microvascular occlusion.
The skins.
Neurologic pathology is also common and diverse, beyond stroke. Chronic cognitive dysfunction, unusual coriform movements, recurrent seizures, white matter hyperintensities on imaging disproportionate to age, cerebral edema, and cerebrovenous sinus thrombosis.
What about lungs and kidneys, frequent targets in critical illness? How does APS specifically hit them?
Absolutely. Involvement could be severe, life-threatening. Pulmonary hypertension progressing to right heart failure, diffuse alveolar hemorrhage, widespread lung bleeding, presenting as hemoptysis, acute respiratory failure, and recurrent or large BE.
Oh.
Renal manifestations are often severe, distinctive. APS nephropathy is a distinct entity, characterized by thrombotic microangiopathy, TMA, and renal cortical necrosis. Remember TMA? Tiny clots in small vessels causing organ damage, fragmented red cells, schistocytes, low platelets.
Right, TMA.
In APS, this presents as severe hypertension, proteinuria, sometimes nephrotic, rapidly progressive AKI, cortical ischemia signs, even renal infarction. Unfortunately, kidney-limited APL microangiopathy can progress to dialysis dependency. In CPS, renal involvement often means acute tubular necrosis from ischemia or diffuse cortical necrosis, frequently needing CRRT, highlights the microvascular severity.
You mentioned MTO-ACT pathways earlier. How does that specific molecular pathway connect to renal involvement, potential therapeutic target?
Insightful question, linking path to therapy. The MTO-ACT pathway is posited as an important mediator in APS nephropathy and neointimal hyperplasia, that abnormal vessel thickening leading to occlusion.
Okay.
Activation's been seen in endothelium of intrarenal vessels and APL-associated nephropathy. While from an initial report needing more reproduction, there's a compelling clinical observation. Kidney transplant patients with APL nephropathy on sirolimus, an MTOR inhibitor used in transplant, had remarkably minimal recurrence of vascular lesions compared to matched patients not on sirolimus.
Interesting.
Suggests MTOR couldn't indeed be a pharmacologic target, especially for kidney vascular damage. MTOR itself is a central kinase integrating signals for cell growth, proliferation, survival. Its overactivation in APS could drive that dysfunctional endothelium and proliferative vessel wall changes.
What other, maybe less common extra criteria signs should intensivists look out for?
Hematologically, thrombocytopenia is common, 30–50% of patients. Critically, if present with triple APL positivity, LA, ACLA, GGPI, it carries significantly increased mortality risk, odds ratio 2.93.
Wow.
Hemolytic anemia, often Coombs negative, can occur too. Other, less common but significant ones: widespread occlusive vasculopathy, progressive vessel narrowing, a vascular necrosis of hip or other joints, bone ischemia causing pain, destruction, even bone marrow necrosis, rare, severe, can cause pancytopenia, potentially fatal.
Now, obstetric and gynecologic manifestations critical for intensivists managing pregnant patients, as these can become high acuity fast.
Indeed. In pregnant APS patients, obstetric complications primarily involve placental microthrombosis and complement-driven villus damage. Key pathology leading to severe adverse outcomes.
Like what specifically?
Recurrent early miscarriage, before 10 weeks, often 3+ consecutive. Late fetal loss, at or beyond 10 weeks, including stillbirths. APS strongly associated with severe preeclampsia, new hypertension plus proteinuria after 20 weeks. HELP syndrome, hemolysis, elevated liver enzymes, low platelets, life-threatening, and postpartum hemorrhage, maybe from abruption or retained placenta due to vascular pathology.
So for critically ill pregnant patients with these severe complications, APS must be high on the differential.
Absolutely. Critically ill parturients with severe preeclampsia, HELP, or eclampsia, especially when standard causes are lacking or initial therapy fails, should be rigorously screened for APLs. Furthermore, a critical point: CPS itself most often develops in the last trimester or immediate postpartum period. Makes it a crucial differential then. Poses a diagnostic challenge because CPS, HELP, and acute fatty liver of pregnancy can look strikingly similar. Rapid differentiation is tough, but essential.
And the impact on the fetus? It's just secondary to maternal issues or direct fetal impact?
Significant can be direct. CPS isn't just systemic from mother placenta, can directly damage the fetus. There's an association between fetal SIRS, systemic inflammatory response syndrome, and fetal thrombophilia. Highlights that in chronic placental inflammation of internal SIRS, the fetus itself might develop SIRS, contributing to poor outcomes, growth restriction, oligohydramnios, even fetal death. Severe obstetric complications in known suspected APS should always raise strong suspicion for an underlying, possibly catastrophic flare.
So what does this all mean for you, the intensivist? APS is clearly way more than just DVTs or strokes. It's systemic, bewildering array of manifestations: skin, kidneys, lungs, heart, brain. For you, these extra criteria signs can be the initial confusing clue in unexplained multi-organ dysfunction.
Exactly.
Remember, significant placental involvement can drive severe obstetric complications, landing patients in your ICU. This breadth makes APS a true diagnostic chameleon. Here's another board-style question. A 60-year-old male, new cognitive dysfunction, history of libido reticularis, presents to ICU with AKI. Labs: rapidly rising creatinine, significant proteinuria, schistocytes on smear, APL panel pending. Which renal pathology is most consistent with APS-related kidney involvement here?
Yeah.
A, acute interstitial nephritis. B, minimal change disease. C, thrombotic microangiopathy, TMA, with potential cortical necrosis. D, IgA nephropathy.
Okay, the answer is C. Thrombotic microangiopathy, TMA, with cortical necrosis. That constellation cognitive dysfunction, blood veto history, AKI with proteinuria, especially schistocytes pending APLs, strongly points to APS nephropathy, characterized by TMA, often leading to cortical necrosis. The others fit less well with the full picture.
Perfect. Let's move to Chapter 4. Catastrophic Antiphospholipid Syndrome, CAPS. The thrombotic storm unveiled, the most acute, devastating form we're focusing on.
Right. Catastrophic APS, CAPS, is the most severe, aggressive, acutely life-threatening manifestation. A highly thrombotic phenotype characterized by explosive, widespread microvascular thrombosis. Despite advances, mortality remains grim, around 30%.
Still so high.
Still very high, though an improvement from historical rates near 50%, likely due to better early diagnosis and more aggressive treatment.
How is CAPS specifically characterized clinically? What does this thrombotic storm actually look like in an ICU patient?
Clinically, CAPS means rapid development of widespread microvascular thrombosis, causing acute ischemic injury across multiple organ systems simultaneously. Patients classically have circulating APLs, usually high titer, though testing can be delayed acutely. They develop involvement in 3 or more major organ systems: kidneys, lungs, brain, heart, GI, skin, with histopath evidence of small vessel occlusion if biopsy is feasible. Crucially, all this happens fast, simultaneously, or within less than a week, an acute, generalized assault on the microvasculature.
And does the two-hit concept apply here too? In this most dramatic form, what typically triggers this devastating storm?
Absolutely. The two-hit concept is dramatically acutely evident in CAPS. This picture, unlike classic APS, which can be chronic, is almost always preceded by an identifiable trigger, most common. Severe infection sepsis, pneumonia due to the profound inflammatory procoagulant response.
Infection again?
Yes, but other triggers. Underlying malignancy, certain drugs, less common, major surgery, stress, inflammation, injury, or, as highlighted, abrupt anticoagulation withdrawal or subtherapeutic INR in an APS patient. It really reiterates the two-hit concept in its most dramatic, life-threatening form, underlying procoagulant state suddenly, violently unleashed by a powerful stimulus.
So like a sudden, uncontrolled explosion of clotting hitting multiple organs almost simultaneously. Heard it described with powerful analogies.
Yes, often called a thrombotic storm, rapid, widespread, uncontrolled microcirculatory clotting. When associated with SLE, sometimes even a tsunami, reflecting its overwhelming, devastating systemic impact, making it particularly tough to manage.
Let's make it concrete for intensivists. Go over the specific formal classification criteria for definite CAPS, essential for board exam level understanding.
Okay, for definite CAPS, all 4 international criteria must be met. 1. Objective evidence of involvement of 3 or more distinct organs, systems, and/or tissues. Clear signs of dysfunction needed.
3 or more. Got it.
2. Manifestations developed simultaneously or rapidly within less than 1 week. Rapid onset is key.
Less than a week?
3. If biopsy is feasible and safe, histopathological confirmation of small vessel occlusion in at least 1 affected organ tissue. Direct microvascular evidence.
Histoproof if possible.
4. Laboratory confirmation of antiphospholipid antibodies, LA-ACL, and/or a K2-GPI consistent with APS diagnosis. Need those labs, though initial treatment might start empirically.
What about cases where not all four strict criteria are met, but the picture screams HEAPS, especially in a deteriorating ICU patient? Is there a probable category?
Yes. Recognizing urgency and challenges, there are criteria for probable CIPS.
Yeah.
Can be diagnosed if 1. All 4 definite criteria met except only 2 organs involved, not 3 plus 2.
Really?
2. All 4 met except lab confirmation isn't 6 plus weeks apart, e.g. patient dies early, never tested before, persistence unconfirmable.
Crucial exception.
3. Criteria 1, 2, 4 met, multi-organ, rapid onset, APL positive, but without histopathology. Biopsy too risky, not feasible. 4. Criteria 1, 3, 4 met, multi-organ, histo-proof, APL positive. But the third event develops after 1 week but less than 1 month, despite anticoagulation. These allow clinical judgment in challenging situations, guiding early intervention even if not all definitive criteria met immediately.
Given its extreme severity, what specifically drives mortality in CIPS? And what's the actual rate we should prepare for?
Mortality, as mentioned, remains tragically high, 30% even now, improved from 50% pre-2001, likely due to better diagnosis treatment. Primarily driven by progressive multi-organ failure from widespread microvascular thrombosis and severe infectious complications, often linked to that precipitating event. A large 10-year European CIPS registry study, 1,000 APS patients, found 9.3% died overall. Of the 9 CIPS patients in that cohort, 0.9% of total, 5 died, 55.6%, underscores CIPS severity. Most common death causes across broader APS cohorts: major thrombosis, 36.5%, infection, 26.9%. Also observed, thrombocytopenia, especially with triple APL positivity, associated with significantly increased mortality, or 2.93, versus APS patients without thrombocytopenia. Suggests more aggressive phenotype.
Let's really bring this to life with specific ICU scenarios, case examples. Illustrates the diverse, challenging presentations, diagnostic dilemmas. Walk us through some compelling cases.
Certainly. One challenging case highlighting CAPS fulminant nature: 22-year-old female, known SLE, presented with profound anasarca, generalized swelling, severe thought disorders, acute neural involvement, ICU labs, severe anemia, profound thrombocytopenia, positive ANA, LA. Despite aggressive care, rapidly developed massive PE, left MCA infarction, stroke. Sadly, despite aggressive therapy, experienced refractory cytokine storm, similar to severe sepsis, ultimately succumbed to neutropenic sepsis. Highlights rapid, overwhelming nature, dual hit of thrombosis infection.
Another patient sounds like they presented with seizures, common ICU presentation, could mask underlying SAPS.
Indeed. Another poignant case: 23-year-old woman, known FLE, history, oral aphtha, polyarthritis, Raynaud's, intermittent fever headache, prior arterial thrombosis history, rapidly developed CIPS with new onset generalized tonic-clonic seizures, papilledema, increased ICP, brain MRI, crucial, revealed extensive superior sagittal sinus thrombosis, severe cerebral venous sinus thrombosis. Fortunately, in this case, acute condition resolved with prompt, adequate multimodal therapy. Shows early recognition can lead to positive outcomes.
And severe renal involvement, especially linked to SLE.
A case vividly illustrating severe renal widespread arterial involvement: 47-year-old woman, known SLE, class 4 lupus nephritis history, admitted with acute paraparesis, light weakness, ominously absent lower limb pulses, severe limb ischemia. CT confirmed widespread mesenteric ischemia, life-threatening, needing emergency colectomy. Underscores how widespread arterial involvement can be brain, heart, critical visceral organs, leading to multi-organ failure.
Sounds like intestinal involvement can be particularly devastating, needing emergency surgery.
Absolutely can, often associated with even greater mortality from sepsis MOF. One documented case: young man admitted severe abdominal pain, vomiting, peritonitis signs. CT showed pneumoperitoneum, ruptured bowel.
Oh, dear.
Diagnostic laparoscopy confirmed extensive small intestine necrosis from small vessel thrombosis, colon spared. Fortunately, after extensive surgery critical care, transferred to rehab, positive outcome for such severity, but highlights acuity of gut ischemia in CIPS.
What about patients with pre-existing genetic clotting factors? Can having 1 plus APS make CTIPS worse or complicate things?
Absolutely can. Creates a perfect storm, particularly complex CPS case. 25-year-old female already had prothrombin G2210A mutation, heterozygous factor V Leiden, common thrombophilias, also on combined OCPs for 6 months, known risk.
Multiple hits.
Multiple hits. Initially presented worsening neck shoulder pain, then rapidly acute SOB, chest pain, CTs, massive PE, pericardial effusion. Despite initial therapy, condition worsened dramatically. Cerebral edema, to subacute brain infarcts. Tragically, extensive necrotic changes, both upper extremities needing amputation due to critical limb ischemia.
Devastating.
Subsequently tested positive for high-titer LA. Case powerfully illustrates how underlying genetic thrombophilias, external risk factors, OCPs, can converge with APS to create a truly catastrophic, rapidly progressive thrombotic picture. Makes management incredibly complex.
Pregnancy and postpartum seem particularly high risk for CPS. Specific examples of this devastating presentation, then.
Peripartum is indeed uniquely high risk, often an obstetric emergency. Critical case. Patient 2 days postpartum, multiple aches, pains, worst abdomen, lower back, rapidly developing pancytopenia. Bone biopsy, investigating pancytopenia, shockingly showed extensive bone marrow necrosis, rare, incredibly severe microvascular thrombosis manifestation.
In the marrow. Wow.
Clinically recovered acutely after intensive treatment, but later developed progressive myelofibrosis, myelosclerosis, chronic sequelae. Another tragic, often fatal case of bone marrow necrosis plus liver, lung, CNS involvement occurred during a previous pregnancy. Emphasizes systemic, often lethal nature of CPS here.
And the eyes. Mentioned microvascular involvement earlier. How does it specifically present in eyes during a CPS?
Ophthalmic manifestations in CPPS are relatively common, often bilateral, 83%, can cause significant permanent vision loss. Most often occlusive retinopathy, retinal vessels 74%, choroidopathy, choroid layer 48%, or retinal vasculitis, less common, 4%, can lead to acute vision loss, cotomas, blindness, emphasizes widespread microvascular occlusion, even seemingly less critical organs.
CPS is truly like a runaway train, relentlessly gathering speed, indiscriminately hitting multiple vital organ systems simultaneously. The key, as an intensivist, is recognizing early signs of this thrombotic storm, its systemic devastation, before irreversible damage, because, as we've heard, outcomes can be devastating, life-altering. Early, decisive intervention is paramount. We've just described the devastating clinical reality of catastrophic APS, rapid, widespread microvascular thrombosis, multiple organs, often an identifiable trigger. We covered formal classification criteria, simultaneity, multi-organ involvement, rapid onset are key,
Right.
and tragically discussed high mortality driven by MOF, infection. This is precisely where your rapid diagnostic acumen and therapeutic intervention become absolutely critical as an intensivist. Recognizing it quickly can literally mean life versus death or devastating disability. For your flashcards, here's a mega recap of absolute key points from this chapter.
CPS definition. Remember, rapid widespread microvascular thrombosis, AV the 3 organs, 1 week. Histopathology, if feasible. Confirmed persistent APLs. All 4 for definite CPS.
Mortality. 30%, down from 50% historically. Driven by MOF, ischemia, and infection, often linked to second hit.
Triggers. Key second hits. Severe infection, most common. Major surgery, malignancy, pregnancy, late postpartum. Critically, anticoagulation withdrawal, subtherapeutic INR. Vigilance needed.
Key pathophysiology, exaggerated microvascular thromboinflammatory state. Driven by uncontrolled complement, significant endothelial platelet activation, widespread microthrombosis, tissue damage.
Renal involvement in CPS, often ATN ischemia, widespread cortical necrosis, frequently leads to AKI needing CRT, highlights severity of kidney microvascular damage.
All right, let's transition to Chapter 5, Navigating ICU Management, the Triple Therapy and Adjuncts, shifting from understanding to actively fighting it.
Okay, when it comes to standard of care for CPS, the approach centers on the widely known triple therapy. This multimodal combo is designed to rapidly counteract TPS complex pathophysiology, targeting both hypercoagulable and hyperinflammatory parts. Includes aggressive therapeutic dose anticoagulation, powerful immunosuppression with high-dose corticosteroids, and either plasmapheresis or IVIG to remove antibodies and modulate immune responses.
What's the evidence base for this triple therapy, given how sick these patients are, the urgency? Randomized trials or more consensus?
Recommendations mainly supported by expert consensus from leading groups. McMaster Rare Best Practices, 16th International Congress on APL Antibodies Task Force. They reviewed available evidence, largely case series, registry data due to CPS rarity, and endorsed triple therapy, crucial for intensivists. While all 3 used together, therapeutic dose anticoagulation gets a strong recommendation due to direct survival impact. Other therapies, high-dose steroids, Polexvig are conditionally recommended, strongly suggested based on experience evidence, but maybe not same level of definitive RCT data. Interestingly, while no statistically significant difference in recovery for specific combos in CIPS registry, clear trend towards higher recovery with combined therapy, especially post-2001 when combo use increased. Recovery 69% with AC plus GC plus PE-EAG versus 54.4% without, 77.8% with AC plus GC plus PE versus 55.4% without.
That's a noticeable difference.
Significant shift coincided with notable decrease in overall CIPS mortality, fell from 53% pre-2001 to 33% in 2001-2005.
Let's break down the individual components. Anticoagulation, you called it fundamental. Agent of choice in acute ICU. Critically, how monitor efficacy in APS given antibody interference potential?
Full-intensity anticoagulation is absolutely fundamental, paramount, directly addresses the thrombotic storm. Acute ICU agent of choice, typically intravenous unfractionated heparin, IV, USA.
Okay, UFH.
Continuous infusion, titrated to goal anti-ASA level 0.3 to 0.7. Amela, vital for intensivists to apply this. Monitor anti-ASA levels, not APT.
Right, that's the key pearl.
Because loop anticoagulant, common and significant in APS, interferes with APTT, giving falsely prolonged results that don't reflect true anticoagulation. Relying on false APTT could lead to under-anticoagulation, risk further catastrophe.
How important is anticoagulation for survival? Does it really make that difference alone?
Stands out as only single therapy consistently showing statistically significant effect on improving vital prognosis survival. Pooled data shows survival 63.1% with anticoagulants versus dismal 22.2% without. Highly significant OR 5.98.
Huge difference.
Unequivocally underscores its paramount importance. Critical caution. Maintain full therapeutic anticoagulation even during sepsis, MOF, unless active life-threatening bleeding mandates temporary stop. Mechanical compression devices, only supplementary adjuncts, never monotherapy for preventing CIPS thrombosis. Not sufficient.
Moving to immunosuppression. High-dose glucocorticoids, how typically used to combat rampant inflammation.
High-dose steroids are key, immediate component. Typical acute CIPS regimen. IV methylprednisolone, pulse dose, 1 gram a day for 3 days.
Pulse steroids.
Then rapid taper, often to 1 mg a day oral prednisone equivalent. Subsequent slow taper depending on response. Example regimen reported.
Right.
Methylpred 1 game day 1, 0.5 GB 2, 0.5 GB day 3, and prednisone 1 mg a day tapered.
Okay.
Primary role. Powerful, broad immunosuppression. Rapidly suppress overwhelming systemic cytokine cascade, generalized inflammatory response, fueling severe inflammation clotting. Buys time for other therapies.
And third leg, plasma exchange or IVIG. Rationale, typical protocol, how to choose between them.
Goal of PLEX or IVO. Emergently reduce circulating pathogenic APL burden, further suppress runaway cytokine cascade complement activation. For PLAX, typical protocol, exchange 1.0, 1.5 plasma volumes daily for 3 to 5 consecutive days.
Okay.
American Society for Apheresis, ASA, gives PLEX grade 2C recommendation for CIPS. Conditional, low evidence, strong benefit. Particularly indicated if CIPS shows serological microangiopathy, features schistocytes on smear, severe thrombocytopenia.
What about replacement fluid for PLEX? Consensus.
No definitive consensus. Historically, FFP, human albumin, solvent detergent plasma used, each pros cons, FFP factors reactions, Yeoman's Inferno factors. ASA often suggests combo plasma albumin to balance benefits risks, therapeutic benefit, minimize side effects, allergies, citrate toxicity. Suggestion often 5% albumin solution, especially if volume electrolyte concerns paramount. If PLEX unavailable, challenging, contraindicated, IVE is important alternative. Typical protocol. 0.4 g/kg day for 5 days.
IVIG benefits.
Thought to decrease pathological antibody synthesis, modulate B cells, increase their clearance, suppress cytokines, modulate T cells, broad immunomodulatory effect, but administer with caution. Potential side effects include AKI, certain formulations patients, paradoxically thromboembolic events, especially if full anticoagulation contraindicated due to bleeding. Careful risk-benefit needed.
What about patients who don't respond to initial triple therapy, or those with recurrent thrombosis after seemingly stable APS management? Step-up strategy for refractory recurrent APS beyond acute CAPS.
For recurrent thrombosis despite optimal VKA, step-up needed. First, confirm adherence, therapeutic INR history. Second, rigorously exclude other causes like HIT. Then, consider high-intensity VKA, INR 3 to 4, higher target, or switch to therapeutic LMWH twice daily, subcutaneous, often preferred long-term, more consistent anticoagulation.
Okay.
Additionally, for chronic management, add hydroxychloroquine, HCQ, low-dose aspirin, anti-inflammatory, antiplatelet effects. For more severe refractory non-criteria manifestations or severe cases like complement-driven microangiopathic recurrent CPS, more targeted immunomodulation, rituximab, eculizumab, shown promise in case series inducing remission. Recommended in specialized centers, often salvage therapy.
This raises an important question for intensivists on the front lines. How do we effectively fight this storm? Core strategy for CPS and ICU is unequivocally triple therapy, aggressive therapeutic anticoagulation, IV-UFH, monitor anti-Zax, high-dose steroids, methylpred pulse, and PLEX, or IV, to reduce antibody cytokines.
That's the triad.
Remember, anticoagulation has strong recommendation, underscoring thrombotic nature, but combining modalities offers best survival chance. For refractory cases, start thinking targeted immunomodulation, which we'll cover next. Here's a board-style question for clinical practice. ICU patient, definite CPS, on IV-UFH, methylpred, daily PLEX. Condition worsening. Reviewing coag study, markedly prolonged APTT, suspect inaccurate. Most appropriate next step for monitoring heparin efficacy. A. Continue monitoring APTT daily. B. Immediately switch monitoring to anti-AXA levels. C. Increase heparin based solely on clinical thrombosis progression. D. Discontinue heparin due to presumed refractoriness. Switch without lab confirmation.
The correct answer is B. Immediately switch monitoring strategy to anti-XE levels. Given likely APLs, especially LA, ATTT is notoriously unreliable, can be falsely prolonged, misleading you. Monitoring anti-XA is crucial to accurately assess heparin's true therapeutic effect. Ensure adequate anticoagulation in APS, especially with worsening thrombosis.
Let's move to Chapter 6, Emerging Therapies and Future Directions, where innovation and research push boundaries in APS treatment.
Our understanding of APS pathogenesis has really grown, prompting investigation into new, more targeted therapies beyond conventional broad anticoagulants immunosuppressants. One incredibly promising avenue: biologics specifically targeting B cells, the antibody producers.
Why B cells specifically? Rationale there.
Rationale stems directly from their central role producing pathogenic APLs, particularly anti-beta-2 glycoprotein I, a key driver. By modulating depleting B cells, aim is to directly reduce problematic autoantibody generation concentration, disrupting the root autoimmune cause. Precision approach.
Key B cell targeting agents explored or used for refractory APS.
Rituximab, anti-CD20 monoclonal, is prominent, most widely studied B cell depleter in APS mechanism. Binds CD20 on B cells, depletion to decrease pathogenic autoantibody generation, shown to significantly reduce APL levels in refractory cases, improving outcomes. Systematic review, 20 CPS patients getting rituximab plus first-line therapy for aggressive presentations, found 15 recovered acutely. 4 remarkably achieved negative APL profile. Profound effect. Critically, rituximab shown to improve kidney function, resolve cerebral edema in CIPS, even some isolated cases without full anticoagulation, the not standard practice.
Impressive. Benefits beyond acute CPS.
Yes. Utility extends to chronic refractory APS. Retrospective study, 63 SL APS patients, 6 under rituximab showed no thrombosis relapse, significant lupus activity reduction. Another study, 24 primary APS under rituximab, found 75% response rate across various manifestations.
What kind of manifestations?
Refractory VTE, arterial thrombosis, chronic thrombocytopenia, hemolytic anemia, diffuse pulmonary hemorrhage, overlap syndromes may benefit APS plus concurrent malignancy. Notably, successful pregnancy in refractory primary APS women, severe thrombocytopenia unresponsive, weekly rituximab, 12-15 double case gestation, increased platelets, decreased ACL, successful pregnancy.
So promise in controlling disease, reducing pregnancy complications, especially refractory cases.
Yes, but remember, McMaster Rare Best Practices recommended avoiding first-line CBS treatment with rituximab, reserved for refractory cases where initial triple therapy failed inadequate, given immunosuppressive effects.
Other B-cell agents on horizon beyond rituximab?
Field evolving. Daratumumab, anti-CD38 monoclonal, explored, primarily myeloma, targets CD38, Ag-kappa, depletes plasma cells, plasmablasts, ultimate antibody producers. Clinically significant improvement seen in APS patient with refractory recurrent VTE despite intensive anticoagulation. APL levels declined significantly. Used ex vivo too. Other B-cell targets under investigation potentially for APS. Belimumab, anti-BLIS antibody. Telitacicept, fusion protein targeting BLAS in April. Zanubrutinib, BTK inhibitor targeting B-cell receptor signaling. Next-gen precision B-cell modulation.
Beyond B cells, you emphasized complement's central, uncontrolled role in CPS, biologists targeting that pathway. Experience with them.
Absolutely. Uncontrolled complement activation central, critical in APS path. especially CPS rapid, devastating microvascular thrombosis, strongly corroborated by high prevalence, up to 60%, complement regulatory gene variants, CFH, CFI, CD46, C3, in TPS patients. These likely contribute to inability to restrain amplification once triggered, makes complement very attractive target.
And main drug here is eculizumab, right? Mechanism, success in CPS.
Correct. Eculizumab, leading complement inhibitor explored for CKSS, humanized monoclonal, binds high affinity to C5 protein, inhibits cleavage to C5a, C5b, prevents C5b9 membrane attack complex, MEA's generation terminalytic part, causing cell destruction and inflammation.
Big success in AHUS.
Radically improved AHUS outcomes, where uncontrolled complement also core issue, transform fatal disease to manageable. Building on this, increasing clinical reports in International CPS Registry describe eculizumab benefits in CPS, particularly refractory to standard triple therapy, even used prophylactically successfully in CPS patient undergoing renal transplant.
Walk us through a specific eculizumab case. Illustrates potential challenges, maybe timing important.
Certainly. Complex illustrative case. 45-year-old man, history, triple positive primary APS, previous PTE, chronic lower limb ulcers, on warfarin. Presented intense asthenia, fatigue, acute dyspnea,
Okay.
ICU labs, severe pancytopenia,
Yeah.
imaging, multiple splenic infarctions, later developed acute acalculous cholecystitis, extension of splenic infarcts, severe headaches plus small ischemic brain lesions, CKS diagnosis, thrombocytopenia, multi-organ, spleen, brain, marrow, possibly liver. Despite escalating fondaparinux, high-dose methylpred pulse plus taper HCQ condition worsened.
Oh, dear.
Developed a rapidly progressive renal failure, active urine sediment, severe HDN, renal biopsy too risky. Despite subsequent IV-AB, then rituximab, kidney failure progressed inexorably, chemodialysis needed.
What happened next with eculizumab in this dire situation?
At this point, sophisticated testing revealed marked C5b9 formation on his cultured microvascular endothelial cells. 208% resting, 263% activated, normal 150%.
Yeah?
Confirmed profound complement activation. Importantly, level completely normalized after in vitro eculizumab exposure, potent inhibitory effect.
Wow.
Genetic assessment then revealed polymorphic heterozygous deletion CFHR3, CFHR1 genes, complement regulatory, genetic predisposition. So timing seems incredibly crucial. Earlier eculizumab makes significant difference, especially organ recovery.
Absolutely appears so. Critical takeaway. Recent case series, APS plus TMA treated with eculizumab, reported lab improvement, LEH, platelets, as early as first week after start. Strongly suggests consider complement inhibition earlier, ideally before irreversible organ damage.
French cohort study, 11 severe triple plus CKPS refractory, shed light on timing. Overall response inconsistent, but T responders generally had less severe APS history. Crucially, fewer required hemodialysis before eculizumab. Among 4 responders with renal failure, 3 recovered renal function, if not on HD, before eculizumab. Patient already on chronic HD remained dialysis dependent.
That's a huge difference.
Strongly emphasizes earlier administration might prevent irreversible lesions, renal cortical necrosis, significantly improve kidney recovery chances. Also, thrombocytopenia improved more rapidly frequently after eculizumab, critical for anticoagulation management. That C5b9 formation test could be a reliable marker for monitoring activation inhibition, guiding therapy.
Incredibly promising for CPAS future, highlighting precision medicine shift. Any other potential targeted therapies explore beyond B-cell complement, targeting other path aspects?
Yes, several intriguing avenues. Sirolimus, MTOR inhibitor, posited mediator APS nephropathy, potential target. Based on one report plus that compelling clinical observation, kidney transplant APS patients on sirolimus had minimal vascular lesion recurrence. Suggests MTOR inhibition might prevent chronic vascular damage.
Okay.
Defibrotide, used in VOD, seems relevant, inhibits APL-mediated net formation, venous thrombosis, directly targets nets.
What about agents targeting inflammation more broadly, or role in chronic APS?
The adenosine receptor agonists,
Yeah.
pirmaphenopyridamole,
Yeah.
shown preclinically suppresses APL-mediated netosis via A2A receptor mitigate VTE. Hydroxychloroquine, HCQ, well-known antimalarial immunomodulator, offers several potential benefits, especially chronic management.
How does HCQ work here?
Mechanisms. Protects annexin A5 anticoagulant shield from APL disruption. Directly reduces APL beta-2 GPI complex, binding to phospholipid bilayers. Reduces binding to syncytia trochoblasts, placental health. Restores annexin A5 expression. Improves endometrial angiogenesis, relevant obstetric APS. HTQ can be added for refractory APS with recurrent thrombosis despite optimal VKA. Extra immunomodulation protection layer.
Any other truly cutting-edge therapies in development investigated?
Yes, frontier personalized medicine explored.
Yeah.
TNF's blockade investigated one ongoing study, adding certolizumab, TNF alpha blocker, to standard care, improved pregnancy outcomes,
Mm.
even more cutting edge. Remarkable case study details successful CD19 targeting TAR T cell therapy in 67 HEO, long-standing severe refractory APS. Demonstrated potential as precision immunotherapy depleting A2GPI-specific autoreactive B cells. Glimpse into highly personalized antigen-specific therapy.
Wow, CAR-T for APS.
Finally, preliminary preclinical mechanistic studies explored potential common supplements. CoQ10, ginger, vitamin D, showed some promise modulating inflammation coagulation pathways. Certainly not standard therapies yet. Need much more rigorous investigation.
Let's turn to Chapter 7, Practical Considerations in Critical Care, where rubber meets road for intensivists translating complex knowledge into real-world patient management.
Absolutely. Managing critically ill EPS patients, particularly around surgery, meticulous perioperative anticoagulation management is paramount. For patients on VKAs, warfarin undergoing high thrombotic risk surgery, standard practice, bridge with therapeutic LMWH and oxyparin,
Bridging?
discontinue warfarin, start LMWH when INR drops, perform surgery, restart anticoagulation post-op. Post-op, once hemostasis secure, bleeding risk decreased. LMWH typically restarted 12-24 H's after major surgery, sooner for minor. Minimize unprotected time. Warfarin restarted, overlapped with LMWH till INR therapeutic.
What about anticoagulation monitoring in specific critical care scenarios, ECMO, CRRT, where coagulation already is so complex?
Crucial point can lead to significant errors. ECMO or CRT patients, heparin often used for circuit anticoagulation, imperative monitor anti-L levels for efficacy. As discussed, LA presence messes up APTT assays, falsely prolonged results.
Right, the anti-AXO again.
Relying on APTT could lead to erroneous conclusion of adequate anticoagulation when severely under-anticoagulated, major risk for catastrophic thrombosis, native vessels, circuit. Maintain full therapeutic anticoagulation during sepsis-MOF, only cease if active life-threatening bleed mandates it. Mechanical compression devices, useful adjuncts. Never model therapy for thrombosis prevention treatment in high-risk APS. Inadequate protection.
A lot of discussion, evolving evidence about DOACs versus VKAs in APS, especially DOAC convenience. Latest nuanced guidance. Are they ever safe?
Very important point. Significant, potentially life-saving implications.
Yep.
VKAs, warfarin, unequivocally remain gold standard, superior to DOACs for vast majority thrombotic APS patients.
Unequivocally.
Multiple large prospective studies, RCTs, explicitly failed to show non-inferiority safety efficacy of DOACs versus warfarin for thrombotic APS. More specifically, DOACs found unsafe in high-risk APS, especially triple-positive or arterial APS stroke history.
Unsafe.
Notable cautionary example, Astro APS study, apixaban versus warfarin RCT, stopped early, disproportionate 623 in apixaban arm, had recurrent ischemic strokes versus 025 in warfarin arm. Raised serious concerns about DOAC efficacy for arterial events.
So international guidelines pretty clear then.
Yes, evolved to reflect this critical evidence. 2019 ESC, ASH guidelines, both recommended against DOACs in all APS patients. Safety efficacy concerns. Other major bodies, EULAR, BSH, ISTIF, more nuanced, but primary stance remains. Warfarin first choice long-term anticoagulation.
But some exceptions.
Acknowledged DOCs could potentially be considered in very specific, carefully selected circumstances. Rare exceptions. Non-triple positive patients already stable on DOAC, no recurrent thrombosis, unwillable frequent INR monitoring, documented low VKA adherence despite efforts, history, serious VKA adverse events, severe bleed, skin necrosis. But for high risk, triple plus E, arterial history, message clear, unequivocal, VKA is preferred, safest choice.
We talked second hit triggering CAPS. How actively prevent those triggers beyond acute phase as long-term management risk reduction?
Preventing second hit, crucial long-term, preventing recurrence.
Wow.
For all EPS patients, especially recovering critically ill, rigorous control, conventional cardiovascular risk factor, comorbidities mandatory. High BP, diabetes, hyperlipidemia, smoking cessation. These predispose to endothelial injury inflammation, chronic second hit triggers.
Right.
For thrombotic APS patients, maintaining continuous, lifelong anticoagulant therapy, appropriate INR, generally 2.0, often 2.5, 3.5 recurrent events, essential secondary prevention. Critical point. Anticoagulation, discontinuation, subtherapeutic INR trigger 8% CAPS episodes. Healthcare providers must carefully consider pausing anticoagulation, surgery, biopsy, dental, meticulously weigh thrombotic versus bleeding risk, often a careful LMWH bridging needed during vulnerability.
Finally, ICU differential diagnoses. Constantly thinking about complex presentations. What else high on radar when considering CAPS given its mimickers?
Differential for CPS in critical care broad complex. Many conditions mimic widespread microangiopathy, MOF. Always consider CAPS-like disease when patient presents this way. Even if not meeting strict criteria, immediately allows empirical treatment. Other TMAs.
High on list.
Stachyas, Chica toxin, E. coli, HUS, often GI infection, atypical HUS, uncontrolled complement activation, genetic mutations, complement factors, anti-FH antibodies, thrombotic, thrombocytopenic purpura, DTP, severe ADMTS13 deficiency, 5–10%, genetic or antibody mediated.
In secondary TMAs, systemic conditions causing TMA looking like CPS.
Secondary TMAs, diverse critical causes intensivists must recognize. Pregnancy-related, severe preeclampsia, eclampsia, HELLP, postpartum TMA often encountered, challenging to differentiate from CPS. Systemic diseases, SLE itself, scleroderma, renal crisis, various vasculitides can directly cause TMAs. Glomerulonephritis, C3 glomerulopathies, MGUS-associated IgA nephropathy, similar renal features, also malignant arterial HTN, severe infections, HIV, HCV, H1N1. Certain neoplasms can all lead to secondary TMAs closely resembling CPS. Maintain broad, discerning differential. Remember complexity. Consider specific SLE plus CAPS overlap, 6 and APS. General concept thrombotic storm, thrombosis begets thrombosis, vicious cycle.
Lastly, connection between APS, especially TPS, and recent SARS-CoV-2 pandemic saw lots of clotting inflammation in COVID patients, direct link or shared pathophysiology.
Very pertinent, clinically significant connection, severe SARS-CoV-2 infection, critical forms characterized by significant hyperinflammation, widespread endothelial dysfunction, systemic microthrombosis, often ARDS, MOF, notably elevated ferritin. These thrombophilia manifestations strikingly similar to CAPS symptoms pathophysiology.
So COVID could actually trigger a CAPS event in susceptible individuals.
Yes, precisely the concern. SARS-CoV-2 infection can indeed lead to full-blown CAPS and APS-positive patients, often acting as that potent second hit due to profound indirect complement activation associated systemic procoagulant state it induces.
Shared mechanisms.
Mechanisms of hemostasis disorders in severe SARS-CoV-2. CAPS is remarkably diverse, yet strikingly similar. Shared pathogenic pathways. Both often simultaneous activation, multiple pathways. Prominent platelet activation, intrinsic coagulation, cascade activation, fibrinolysis suppression, DIC, TMA, profound local intravascular coagulation, lungs. Both involve poorly controlled inflammation, hyperactivation, blood clotting, cytokine storm, thrombotic storm. Interestingly, ferritin, marker SARS-CoV-2 severity, macrophage activation, also frequently elevated in many CAPS patients. Shared inflammatory axis.
Truly fascinating, sobering how COVID-19 can trigger CAPS-like phenomenon in susceptible individuals, given shared inflammation thrombosis pathways. Powerful illustration how body fighting one threat can inadvertently unleash another devastating one due to inherent vulnerabilities, makes screening for APL and severe COVID with unexplained thrombosis even more vital.
Exactly. Complex interplay immune dysregulation, hypercoagulation is shared pathogenic mechanism. Critical to consider APS, especially CAPS, and differential for severe COVID presentations with unexplained thrombosis or MOF.
We've covered a tremendous amount of ground in this deep dive into antiphospholipid syndrome and its catastrophic variant CAPS. To reiterate the most crucial, clinically actionable points for you, the critical care intensivist. Catastrophic APS is a true medical emergency demanding prompt, almost immediate recognition. Hallmarks: rapid onset multi-organ failure, often identifiable trigger, presence of APLs.
The fundamental two-hit model is absolutely essential for understanding its acute, devastating presentation in critically ill patients, where an inflammatory or injurious trigger unleashes the underlying insidious procoagulant state.
Cornerstone of acute SAC-PS management in ICU is triple therapy: aggressive therapeutic anticoagulation, high-dose systemic steroids, and PLEX or IVIG. Remember, therapeutic anticoagulation paramount. Strongest recommendation for improving survival.
And looking ahead, emerging biologics, especially complement inhibitors like eculizumab, hold significant transformative promise for refractory cases. Timing of administration potentially incredibly critical for organ recovery, preventing irreversible damage. Early intervention can halt microvascular injury progression.
Finally, practical critical care considerations vital daily. Manage anticoagulation carefully. Avoid DOACs, high risk. Strictly monitor anti-osteo, crucial for safety. Always remember APS mimics or triggered by other critical illnesses demanding broad, discerning differential, other TMAs, so you don't miss this life-threatening condition.
As intensivists, we're often at the sharp end of complex multisystem diseases demanding rapid diagnostic acumen, therapeutic precision. With APS-CAMPS, we explored intricate, often devastating dance between autoimmunity, inflammation, coagulation. Journey from initial antibody recognition to widespread thrombotic storm, profound testament to body's complex vulnerabilities, delicate balanced protective systems.
This brings us to a final provocative thought for you. What further breakthroughs in precision medicine, perhaps advanced diagnostics like single-cell analysis or even more targeted antigen-specific immunomodulators, will truly allow us to halt this thrombotic storm at its earliest, almost imperceptible rumblings, fundamentally transforming catastrophic diagnosis to manageable chronic condition? How will our understanding of second hit evolve to prevent these crises altogether?
We encourage you to reflect on these possibilities and, in your next shift, consider what subtle clinical signs in your critically ill patients might suggest an underlying APS or CAPS, prompting you to think about early diagnoses and the importance of precise, multimodal intervention in these uniquely challenging cases.